Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Oh, Divine Rising. Happy Saturday. It's the Sabbath. Yes. Peace, everyone. So we pick up at page 273. I'm your moderator and narrator, Uriel Neveu Riley. Welcome, YouTube. Peace. All right. Page 273 at the top is where we pick up. Cuff Care. Episode 47 of this book. The area of artificial airway care that has received great attention in the past decade has been that of positive pressure cuffs. We shall discuss this question in great detail in Chapter 17. An essential part of the maintenance of airways is appropriate inflation and deflation techniques of these cuffs. Inflation technique. The object of proper inflation is to place the minimal volume of air in the cuff will allow optimal sealing of the airway. This technique of inflation is called the minimal leak technique or minimal occluding volume. This is based upon the assumption that during positive pressure ventilation, the tracheal diameter is maximal at the time of inspiration. Thus, if the cuff barely occludes during peak positive pressure inspiration, there will be the least possible pressure on the tracheal mucosa during the expiratory phase where the diameter is the least. In other words, a minimal leak should be present at the moment in the ventilatory cycle when the tracheal diameter is maximal. Use of the minimal occluding volume, MOV, necessary to create an airtight seal will act to avoid undue pressure on the tracheal mucosa and thus keep ischemia at a minimum. Recently, there has been interest in actually measuring the intracuff pressure and keeping it below 20 millimeters Hg. Periodic deflation. Periodic deflation of the cuff at various intervals is less beneficial than generally believed. In fact, this periodic deflation and inflation routine may cause the therapist and nurse to be less careful in properly reinflating the cuff. The original purpose of periodic deflation was to restore the blood flow to the tracheal mucosa. There has been no evidence to show that capillary blood flow is restored to the area in less than an hour, and certainly not in 5 minutes or less. Another objection to periodic deflation is that many patients on controlled ventilation do not tolerate the deflation. PEEP, PEEP, cannot be maintained and called cardiopulmonary instability often results. It is our procedure that once the inflation is made with a minimal leak technique and the patient is placed on airway pressure therapy, the cuff is not deflated routinely. A significant change in airway pressures would mean a significant change in the maximal trachea diameter. Under these circumstances, the cuff should be deflated and reinflated. Many patients have high peak airway pressures when first placed on ventilators, and then as they adjust to this procedure or their disease process improves and the compliance and resistance of the lung and airway change, the peak pressures may diminish. Thus, a cuff volume that was producing a minimal leak when the airway pressures were high would be excessive after the airway pressures diminish. This calls for readjustment of the cuff volume. Peace, YouTube. Thank you so much for reading books with us. Peace to the book lovers community we're part of here on YouTube. Thank you so much. We are in the middle of page 274 in the 16th chapter, Maintenance and Extubation of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Peace and highest heart love. Welcome. There are some who advocate periodic deflating of the cuff in order to prevent secretions from pooling above the cuff site. We have found that this can be adequately prevented by appropriate postural drainage and pharyngeal suctioning. If it is necessary to deflate the cuff, certain safeguards must be taken. 1. The trachea must be suctioned. 2. The area above the cuff should be suctioned as well as possible through the pharynx. And 3. The cuff must then be deflated, followed by immediate tracheal suctioning to assure that any secretions lodged above the cuff do not go down into the airway. Applying positive pressure with the cuff down helps blow secretions into the pharynx for easier suctioning and prevents a feeling of shortness of breath on the part of the patient. Some years ago, there were those who advocated using a tube with two cuffs to alternate the areas of cuff pressure. This results in a larger area of tracheal mucosal damage and appears to have no advantage over a single cuff. All right, down the bottom of page 274, with those in the playlist and reading along. Artificial airway emergencies. Thank you so much for the likes and subs in the peaceful part of YouTube where we read books and learn from masters. Highest heart love, Mintu. Thank you so much. Mintu Kumar. Much love. All the aspiring M-techs, breast techs, right? OR techs. This is information that'll be useful. Taking the MCAT, so on and so forth. So we're giving it to you for free. Thousands of dollars of information free on this channel. You can just hit the playlist and read along any of the books. So this is that peaceful part of YouTube. I welcome you and thank you for joining. Artificial airway emergencies. An artificial airway must never be taken lightly. This is best illustrated by a discussion of the immediate artificial airway emergencies. 1. Cuff leaks. 2. Inadvertent extubation. And 3. Obstruction. Cuff leaks. Ventilation must be maintained while preparation is being made for replacement of a tube with a faulty cuff. Often, no more is needed than increased tidal volumes to compensate for the gas escaping. In the case of a tracheostomy tube, it may be possible to support ventilation by bag and mask from above. A leaky cuff prove should not prove a disastrous occurrence since the respiratory care practitioner should be capable of maintaining reasonable ventilation until a new tube can be placed. It is essential that a spare airway of the same size, appropriate intubation equipment, and a hand ventilator with masks be at the bedside of all acutely ill patients with artificial airways. Inadvertent extubation. Replacement of the endotracheal tube or tracheostomy tube should be attempted, but if it cannot be immediately accomplished, the tube should be completely removed. Ventilation must then be established by any means available. This may mean simple mouth to mouth or mask to bag ventilation with occlusion of the tracheostomy stoma. It is unusual when reasonable ventilation cannot be accomplished for short periods of time. The respiratory care practitioner is obliged to assure reasonable ventilation until preparation and personnel can be gathered for replacement of the artificial airway. Obstruction. In the middle of page 275. Peace, YouTube. There is no greater emergency than being confronted with an artificial airway that is obstructed and prevents ventilation. When presented with this circumstance, there are five common etiologies that must be immediately thought of. One, the tube may kink. Slight manipulation of the head, neck, and tube will often correct the circumstance. Two, the cuff can slip or herniate over the end of the tube and cause complete occlusion. This mostly common this most commonly occurs following positional changes of the head and neck and positional changes of the tube. Figure 62, and can be immediately relieved by deflation of the cuff. 3. Plugs within the lumen of the artificial airway may cause partial or complete obstruction. 4. The tube may collapse. This is most common with nasal tracheal tubes that are impinged on by a deviated septum. And 5. The bevel of the tube may impinge upon the carina, the wall of the trachea, or bronchus. This is often relieved by simple manipulation of the tube. Obvious steps when confronted with airway obstruction are to 1. Manipulate the tube, 2. Deflate the cuff, and 3. Attempt to pass a suction catheter. If none of these maneuvers are successful, the tube must be removed. Ventilation must then be established and a new tube placed. When all of these maneuvers have been attempted and ventilation is still not possible, one must think of the existence of a tension pneumothorax. This is a circumstance where there is air in the thoracic cavity under pressure and the lung parenchyma and great vessels are being compressed. Oh, there's a solution, right? A tension pneumothorax must be immediately relieved by opening the chest to the ambient pressure. A rule that must never be broken in intensive care areas is that duplicate airways and appropriate intubation and ventilation equipment must be at the bedside at all times. The best treatment for airway emergencies is prevention. I'll read that again and we'll put a ding dot right there to connect. I'll read that again. The best treatment for airway emergencies is prevention. Have adequate and well functioning equipment at the bedside. Check all tubes and cuffs before placing them in the patient. And constantly reevaluate the function of airway. When faced with a true airway emergency, ventilate any way you can, but ventilate. Middle of page 276. At the top, you see the schematic representation of cuff herniating over the end of the tube and causing obstruction. Here we go. We are in the 16th chapter, in the thick of it. Look at this. All right. So we are reading all together books on this channel on YouTube. This is Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, 1979, second edition. Discontinuing the artificial airway, extubation. The decision to extubate must rise from the general principle that any airway is no longer needed when the indications for its placement are no longer present. Therefore, evaluation for extubation must be made by judging whether or not there is still a need for the artificial airway. Obstruction. If the airway was placed for reasons of upper airway obstruction, the only sure way of testing whether or not the airway is needed is to extubate and watch for recurring signs of upper airway obstruction. Upper airway obstruction is most often due to CNS obtundation. Improvement in sensorium would be an indication for extubation. Protection of the airway. Protection of the airway must involve the evaluation of the airway reflexes. The airway reflexes are obtunded from the top down, i.e., first the pharyngeal, then the laryngeal, then the tracheal, and finally the carinal. It is reasonable to assume that if a patient has a good swallowing mechanism, pharyngeal reflex, with the tube in place, the chances are the laryngeal and tracheal reflexes are intact. Suctioning. The need for tracheal suctioning is great dependent upon the ability to cough adequately. This can be evaluated by measuring the vital capacity, the negative inspiratory force, and judging the level of consciousness. It is reasonable to assume that with an acceptable vital capacity and a cooperative patient, bronchial hygiene can be maintained without an artificial airway. Ventilation. The patient must be free of the need for mechanical support of ventilation before the tube can be removed. Hi, heart love. Welcome, YouTube. That's a very key point. We want to always keep the ventilation going. So we definitely don't want to remove anything that is supporting ventilation without them being able to do it and knowing that it's happening. No one should remove an artificial airway who does not possess the skill and equipment to replace the airway. That's in all capitals here. Middle of page 277. Whenever feasible, extubation should be accomplished during a period of the day when there is adequate personnel, both to monitor and evaluate the patient, as well as personnel who can replace the artificial airway. Endotracheal tube extubation. When the decision has been made to extubate the patient with an indwelling endotracheal tube, there are some basic steps that should be followed. One, The procedure must be explained to the patient to the degree he or she is capable of comprehending. It is desirable to have the patient's cooperation during and after the extubation process. Step 2. That's divine. That's so divine. Secretions must be aspirated from the trachea and then from the oral and nasal pharynx. Step 3. Increased inspired oxygen should be administered. Step 4. The lungs should be completely inflated so that the patient will initially cough or exhale as the tube is taken from the larynx. This is accomplished in two ways. One, the patient is asked to take the deep breath he or she possibly can. And at the very peak of the inspiratory effort, the cuff is deflated and the cuff is removed rapidly. Or two, positive pressure is administered with a hand ventilator, and at the end of a deep inspiration, the cuff is released and the tube removed. Commercial. Peace from India. Oh, thank you so much. Hi, it's Heart Love. Look at that. Isn't it amazing how when you're in a harmonic space, harmony wants you to have its an energy. Oh my goodness, look at that. Oh, Tamrell. Hi, it's Heart Love, Tamrell. Peace, peace. Oh, sending. she's- Oh, hi, it's Heart Love, Tamrell Beauty. Oh, I wish the best. I will give you a call when I finish this reading. Thank you so much. Peace, peace. Oh my. Step 6. The patient's airway is immediately evaluated for signs of obstruction, stridor, or difficult breathing. The patient should be encouraged to take some deep breaths and to cough. Step 7. The patient is not left unattended until there is no doubt of his or her ability to function without the artificial airway. Spare airway equipment must remain at the bedside for a reasonable period. All right, let's see. Paul, if we'll pause right here. I love you so much. I love y'all. All right, we'll keep going. Right? Yep, we'll keep going. Well, shine the light. It's for the people, I do all this because I really love this portion of my life where I can bring peace to you and represent the peace that I've restored in the balance, in the homeostasis of my life. So, being a master fitness trainer, you learn to control the physical, have restraint with the physical, and you learn that everything funnels from the spiritual. So, it's a divine reflection of our balance. I honor all of you that live this peaceful love life and read books and honor all the masters of the universe till all is one. Laryngospasms. Top of page 278. The most common significant problem confronted immediately after endotracheal extubation is spasms of the cords, causing obstruction of the airway. This laryngeal spasm is recognized by an inability of the patient to inspire or the inability to accomplish positive pressure inspiration, in spite of adequate manipulations to clear the upper airway. Laryngeal spasm occurs far more commonly in infants and children than in adults. Laryngeal spasms is usually of limited duration. Some minor air exchange will usually ensue within 30 seconds. High oxygen concentrations with positive pressure may be adequate to maintain oxygenation during this period. If the laryngeal spasm persists, it will be necessary to administer a muscle relaxant to paralyze the vocal cord musculature and allow the patient to be ventilated. Laryngeal spasms can be extremely hazardous in unskilled hands, and its incidence must be kept in mind when contemplating extubation. Thank you so much. Gratitude. Tracheostomy extubation. Here we go. Since the tracheostomy is far more permanent and better tolerated airway, the necessity for early extubation is not as pressing as with the endotracheal tube. However, the indications for removing a tracheostomy tube are precisely the same as for removing endotracheal tube when the indications and needs for the airway are no longer present. A greater degree of flexibility and variability in extubating techniques exits with tracheostomy than with the endotracheal tube. One of the greatest advantages is that the patient can be given a trial at maintaining and using his or her own airway without removing the tracheostomy tube by using a fenestrated tracheostomy tube. A universal fenestrated tube, figure 16.3, is a tracheostomy tube in which a window or fenestration has been cut into the posterior wall of the outer cannula. It is possible to have the patient breathe around the tube and through the fenestration without actually removing the tube. This is accomplished by removing the solid inner cannula and placing a cork in the opening of the outer cannula. Thus, one can evaluate the patient's ability to breathe without obstruction, handle his or her own secretions, protect his or her own airway, and ventilate. A tremendous psychological advantage is that the patient can talk with the fenestrated tube. That's key. That was a key progress in this information. Here we go. Figure 16.3, the fenestrated tracheostomy tube. It says see the text. A depicts the inner cannula without fenestration, and B depicts the outer cannula with fenestration. Peace, YouTube. Thank you so much for likes and subs. Oh my goodness. We are pushing towards 600 subs, moving towards 1,000. Thank you so much for helping us get this far. All the support is so greatly appreciated and loved. And I return it to you with giving you good readings as well as, if I have to, redoing it, right? Yeah. We want the best for the people. We want the best for those around us. So that's why I give you this high level information so you can heal yourself and help to heal others around you. So you can talk with the fenestrated tube, right? Numerous types of fenestrated tracheostomy tubes have been described. It is helpful to have a readily available universal fenestrated tube, which can be placed immediately when it is felt the patient may be able to maintain herself or himself without the tube. This allows a standard tracheostomy tube system to be reestablished simply by replacing the inner cannula, which is unfenestrated, and inflating the small emergency cuff. The inner cannula can also be replaced for suctioning if necessary. This is not intended to be a long term airway device, but rather a method for testing the ability of the patient to exist without the airway in a safe and reversible manner. Commercially available fenestrated tubes have the disadvantage of small fenestrations. The manufacturers believe that larger fenestrations will threaten structural integrity when the plastic material warms. Thus, it may be necessary to place a smaller size fenestrated tube in these circumstances. It is imperative to observe closely for signs of respiratory distress or airway obstruction for several hours after insertion of a fenestrated tube. It may be desirable to keep patent the channel between the skin and the trachea, e.g., if replacement of the tracheostomy tube is contemplated at a later date. This would be beneficial if future surgery is contemplated or if the patient has a recurring disease that may necessitate the reestablishment of an airway. Various types of tracheal buttons have been designed with this in mind. Figure 16.4. They allow the stoma to be maintained open and allow suctioning through the button if necessary. These types of appliances are indicated in patients where it is felt the tracheostomy tube will be needed at some future time, or where suctioning may be required intermittently. Most trach buttons are temporary appliances. A Teflon pr- prosthesis is commercially available, which consists of both an outer hollow cannula and an inner solid cannula. The proper size button is selected by placing a probe into the stoma and measuring the distance between the skin and the interior wall of the trachea. The tracheal button is then fitted to the stoma, corked, and can remain the for indefinite periods with routine skin care. It should be anticipated that the stoma will be completely sealed within 48 hours of extubation. Epithelialization of the canal is rare and occurs primarily when infection is present at the time of extubation. In general, the stoma heals quite well without any suturing. The patient may place have to place pressure over the stoma area to have an effective cough while the stoma is closing. Reassurance should be given that the stoma will be closed in several days. Man, look, my dad. I am so in love. We just completed chapter 16. I love you, Dad. We just completed the book reading. Happy Saturday. Happy Juma. To yesterday's love, to today's love of reading the clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Shaking it up on YouTube, reading books. I wish you have a wonderful Saturday. Doing it. We're doing it. just completed another chapter live from the light here in LA, where we read books and learn from masters, honor those who come before us. Yes, shine the light all over. That's what our words are doing, rippling. That's what our love is doing, rippling into the waters of the earth all around us, creating space to receive love. Thank you. I'm so grateful and thankful for all I have now and all that is coming to me. Shaking it up. Peace, peace. We did it again. Completed another chapter. Yes. Thank you so much. Much love. Oh my goodness. Highest heart love. Thank you for subbing to the channel. Thank you for reading with us. Thank you for breathing with us. I love you. I love you so much. I love you. I love you. You know what? I love myself. I love my family and friends. And I love you. Highest heart love. Have a wonderful Saturday. I will see you soon when we reconvene with chapter 17. Peace, peace.